Welcome back to the RT Clinic. I've got a video today about waveform graphics on a ventilator. I'm going to show you the way I look at them from the time that I go in, some different pressures that I look at. I'm going to try to keep this real easy so that if you're a respiratory therapist, if you're a nurse, if you're a physician, and you're looking at waveform graphics, this will be a good basis for what you're looking for. Because like most people, I like to look at pictures instead of numbers. So let's get this thing started with some waveform graphics. Go. So if we're looking here at this patient, first of all, we're going to see they're on assist control, volume control, assist control. They got a 7.5 tube and have a sigh breath. Settings across the bottom, patient values across this side. This is our scalar waveforms. So most important thing, I like to compare pressure to volume, pressure to flow to volume. Just compare them across. If you notice the green line on here, that's actually automatic tube comp, and that's something that the ventilator is going to do, compensate for the endotracheal tube. It can be somewhat problematic from time to time, especially when it's not riding right along that pressure waveform. So some other things I like to look at right off the bat is we look at our setting, we see our setting of 550, and I like to look up immediately at our tidal volume exhaled. So it's like we're consistently below that, and what the machine's going to do is going to try to compensate to be able to get to that amount of volume. So that's our goal. Another things I like to look at, of course, we have our FiO2 measured here. We have our inspiratory pressure and our mean. We don't have a plateau. To get a plateau, we would do a manual hold. There's our hold, 1, 2, 3, losing pressure as you can tell. So we're not able to get a really good hold in this case. So we have a leak somewhere. I can tell you that right now. You see that hold? It won't hold that in. So generically, our plateau is probably going to be, if I just ballpark it where I see it there, it's probably going to be about 25-ish or so. But we have a leak somewhere. So we have a leak either at the endotracheal tube cuff, could be, and if you notice, this is a pretty fast rate of 30. So one other part about this rate that you're going to see is our ID ratio. So you're like, man, how do you have time to exhale? Well, in this case, patient's very sick, they don't. So ID ratio 1 to 1. So we'll look at some other values on here, but you can see a 1 to 1. So one of the real keys you're going to look at with this, a 1 to 1 ratio is great for oxygenation, but it's very poor for ventilation. Well, how are we compensating for it? Right here, minute ventilation. So we have our high rate, our lowish volume for this size patient, and then we have a good minute ventilation here. Minute ventilation is the absolute key. And if you're wondering about the leak, right there, that's it. We can see we have a leak already in this system, but the machine will compensate for it. But this minute ventilation is really important for ventilation. So if you make any changes at all, it's really key to look at that minute ventilation. That's going to give you the best number for what your if your CO2 is good with this, you want to stay in that range. Some other parts of waveforms I look at. So this one's going along. This doesn't look bad. Of course, you know, the bottom part here is going to be your peep. The top was going to be your inspiratory pressure. That area between the two is going to be your area for ventilation. You see our flow. Let's wait till it catches up here. So there's our inspiratory, expiratory. Comes back to baseline, really doesn't get a chance to. And you can see how that's coming up off a baseline. So we are air trapping, and I'm going to look at that number here in just a second because I know we got to be air trapping with this. And then our volume comes back to baseline, but not quite perfect. Let's take a look at some of my favorite pictures. So we have a pressure volume and a flow volume loop here. So let's take a look at these. So initially coming up off baseline at our peep setting of 12. Not a bad waveform, that it just kind of recalibrates every so often, so that's why it looks whiter. One thing I kind of like to do is I go over here and hit draw and do 10 of them. So it will draw 10 over top of each other. And you can get, if you make some changes, you can see changes in there. Over here is our flow. So you see our flow over time. A couple things I look at: inspiratory going up, end of breath right here. And so you are not coming back before the exhalation starts. You're not coming back to zero. So they were definitely air trapping. You can tell because of that area right there. That should be ending right here and coming back around. So you can also capture a loop, make a change, and see if it does improve it. Run a reference loop if you want to. Let's get in and take a look at our air trapping. So something very kind of special to this type of ventilator, and probably a lot of ventilators these days. We're going to go into Peep Eye. So Intrinsic Peep. So what we actually can do is run a little study, which I hope it's going to let us. Let's see. There we go. Intrinsic Peep. So we're going to go hit start, enter. So you see this was run on February 13th, just a couple days ago. We had Intrinsic Peep, really a set peep of 12 to 13. Intrinsic Peep of 13, so included peep. So this is all of it all together. So we're not trapping a ton. As you can tell, we're not trapping a bunch here because of the 74 milliliters. So this actually gives you a milliliters of trapped. So you look at your peep set and then your total peep is essentially what that is. So peep set and total peep, as long as they're close to one another, that's good. So where are we losing? Well, probably losing it in the leak in this case. So we would hold more of that peep in, but we're losing it inside the leak. So this is a rotoprone patient, very ill, of course. But those are just some different things that I look at with these waveform graphics. Let's go take a look at another set. All right, so the next patient that we have, also a rotoprone patient. Let's look down at our settings. We've got 90% FiO2, 500 for a total volume, 1.0 for the inspiratory time, high rate again, peep at 12. Sounds familiar, doesn't it? I like to look over here at our values, make sure our values are matching. So we're pretty close to 500, so we're getting quite a bit out. You see our leak is 1%, that's very good. PIP at 25. Mean pressure, that's our oxygenation pressure. That's really good. That's our average pressure in the airways throughout 1 minute. That's at 18. So let's do a plateau on this one. Check out this waveform on the top. So manual hold, breath hold. That holds really well. Let off. That should give us a number there, 22. That is a very manageable plateau. With this high rate, you can see we're not going to have a whole lot of extra time to come back to baseline, although it looks like we are, but we'll verify that with that. Actually, we got a little bit of difference there with the flow volume loop. So look at the top here. Of course, our bottom aspect there is our peep level. The top is our PIP, and the area between the peep and the PIP is our area for ventilation. So you also see our green line. That's going to show our tube comp. So like I said, it can be problematic. The tube comp can from time to time, but it looks like it's okay in this one. I kind of like to see it riding a little closer. If we actually would take tube comp off, or let's just greatly decrease the percentage, you're going to see a little bit of change. You can see that waveform change a little bit, maybe more of a full exhalation. And then where we're going to see that change, we're going to see it change on here, and ultimately on the minute ventilation, exhaled. Exhale minute ventilation is really important. Like I was saying before, really good when you look at making the change. When your ventilation is good, but you're going to make a change for oxygenation, you want to keep that the same. So I think it's a pretty good change. We'll leave that there. So we got that. Let's go and look at our pressure volume, flow volume loops. So we're looking at this one here. It's going up. Ooh, and it is doing a minor amount of, what is that, guys? A little bit of bird beaking on the end. So see how it's kind of pointing at the top? It's not very much. Not as dramatic as you'll see in the textbooks, but you can see that going up a little bit. So that means our volume's just going to be a little bit too high. You see we're opening up at 12, starting at 12, and then we're opening up, delivering a lot of volume about the 25 level, and you can see that as you go up. So the angle of this one is about like this. So it looks like a leaf. Of course, when the leaf lays down, that means that the compliance is getting worse. So how do you know if it lays down? We got to capture a loop, and you can see at any point on this what we're reading pressure wise and volume wise. So, or you can run a reference loop, and the cool thing is it says, oh, I did my reference at this time, so then you can watch it and see if it changes over time. Not a lot of people do that, but it's just something we can kind of get into if you want to. And then also, if you want to draw 10, it'll draw 10 over top of each other, and it's kind of neat to do for if you're making a change or suctioning, things like that, especially if you're seeing secretion issues. It's kind of nice to have to draw 10 to see it change, or you can run a reference line too. So let's go back. So on our flow volume loop, if we see it going out, we're changing over somewhere in this area right here is where we're going from inspiratory to expiratory, but it's not a real sharp one. And if you notice, we come back to here, we're not really coming back to baseline here at all either. So we're gonna expect maybe to have a little bit of intrinsic peep. Let's go in and check that on this patient. Let's run a quick one. It's gonna do an expiratory hold maneuver. Bingo. Okay, so we have our set peep at 12, our peep eye, so the total amount of peep is 13.3, and then our volume trapped is 148. So the high rate, low volume, we're expecting to trap some because we are having some oxygenation issues with this patient. So it's one of those options. If you're on an ID ratio like this, this is probably close to a 1-to-1, but let's take a quick look. Values 1-to-1, yeah, so 1-to-1 ratio or inverse ratio. The patient needs to be paralyzed for these cases, and they are in this case, and it is helping with oxygenation, but it's something that we would need to change over time as we come out of it. So there's a couple vents. Those weren't the easiest ones to look at, but we'll do some more at a later video. Thanks for watching. Please comment below if you like this type of video. These patients today were both on rotoprone, really funky graphics, but if you want me to do some more on some other graphics, and if there's other specifics about graphics you want me to go into, I would love to. I think there's nothing more you can do for your patient than learn not just how to read the numbers, but then actually read the graphics to make it the most like real ventilation for your patients. So comment below if you're interested in more videos like this, and I definitely can do that for you. So till later, see ya later.